Welcome to the Deep Dive, the show that takes complex, overwhelming information, especially the stuff that really matters in high-stakes environments, and extracts the critical, actionable knowledge you need.
Today, we're really focusing on interpretation. We're going deep into the intricate world of fluid and electrolyte balance.
Right.
In any clinical setting, a shift in the body's internal chemistry, even a minor one, is often the first signal of a major, potentially catastrophic crisis. The information here can feel dense, but, understanding the system is the ultimate shortcut to informed care.
Absolutely. And our mission today is to move past just reading a textbook and really give you that application-based knowledge. We've pulled material that focuses heavily on interpreting lab values, recognizing the subtle signs of these disorders.
Things like, why is one patient's headache just a headache, but in another, it's a critical warning sign of brain swelling?
Exactly. We need to internalize the management protocols. Like, what do you grab first when a patient's potassium spikes? It's about that immediate correct action.
Right. We want to equip you with the rules of the body's internal ocean, so to speak. You'll learn precisely what happens when the tide goes too high or too low, and how signals, those critical lab values, don't just tell us what happened.
They tell us how and when to intervene to prevent organ failure or even cardiac arrest.
That's the goal.
Okay, so let's unpack this and maybe start with the foundation, fluid dynamics. Before we even get to the electrolytes in the water, we need to know where the water comes from and where it actually lives in the body.
That's a great place to start. So fluid intake is really categorized by its route, and recognizing that route is key to managing the patient's risk.
So we start with the most obvious one.
Oral intake, or PO. This is the natural way, right?
Right.
Drinking water, fluids and beverages, and also the water that's contained in food. A lot of people forget about that.
Oh, sure. Fruits and vegetables, soups, that all count?
It all counts, and in a stable patient, this is the primary source.
Okay, then we have the enteral routes.
Right? Primarily through feeding tubes, like an NG tube or a PEG tube. And while these are essential when a patient can't eat, the critical implication here is managing the concentration of the feed itself.
What do you mean by that?
Well, if the feeding formula is too concentrated, it's hypertonic, it can actually pull water into the GI tract.
Oh, and that would cause some serious diarrhea and fluid shifts.
Exactly. You can be dehydrating your patient while you're trying to feed them, so you have to watch that very carefully.
And finally, the parenteral route.
Yes, the life-saving parenteral route IV fluids. We use this for acute illness, surgery, dehydration, shock. When a patient is MPO for surgery or is in septic shock, this route allows for precise, rapid volume correction.
So monitoring IV fluid administration is probably one of the most hands-on nursing interventions in fluid management.
Without a doubt.
Okay, so once the fluid is in the body, it settles into different compartments. We always hear that we're about 60% water, but it's not just one big pool, is it?
Not at all. It's split between two major locations. And the vast majority, a full 2/3 of all that water, lives intracellularly, inside the cells.
So that's the ICF?
That's the ICF. This is the workshop of the cell. It's essential for metabolism. It's a highly protected space, and shifts of water in or out of the cell are often catastrophic, which we'll definitely get into with sodium imbalances.
And the remaining 1/3?
That's the extracellular fluid, or ECF. This is the environment surrounding the cells. And clinically speaking, this is where all the action is.
And that's broken down even further.
It is, into three really crucial subcompartments. First, you have the intravascular fluid. That's the plasma circulating within your blood vessels. This is the compartment we manipulate most directly with IV fluids to, say, raise someone's blood pressure.
Makes sense.
Then, the largest part of the ECF is the interstitial fluid. This is the fluid that's actually bathing the tissues, sitting between the cells.
Okay, and the last one is the transcellular fluid.
Right, it's small, but clinically it's vital. This is fluid that's functionally trapped in specific spaces. Your cerebrospinal fluid, fluid in your joints, in your GI tract. Normally, it's only about 1 liter total.
But if there's an imbalance, like that abnormal accumulation we call third spacing, this little compartment can become a black hole for several liters of fluid.
That's a perfect way to put it, a black hole.
And it's worth noting, too, that this whole 60% water concept is linked to lean tissue, right? So adipose tissue doesn't hold much water.
An incredibly important point. It's an inverse relationship. A muscular patient holds more water than a patient with a high percentage of body fat. And that influences how quickly you see signs of dehydration and how aggressively you might need to treat them.
Okay, so understanding where the fluid lives sets the stage for the next crucial question. How does it move? How does it cross those borders between compartments? Because that movement dictates everything.
It really does. It dictates whether a patient swells up, shrivels, or can even perfuse their vital organs.
So where do we start with that?
The first dynamic we have to master is capillary exchange. This is the constant push and pull that drives nutrient delivery and waste removal between the plasma and that interstitial space. It's all about pressure.
Okay, so there's an outward force.
Exactly. That's the hydrostatic pressure. The easiest way to think of this is the pressure generated by the heart. It's blood pressure, physically pushing fluid and small solutes out of the capillary and into the tissues.
So it's strongest on the arterial side where it's delivering everything.
Right. But opposing that outward push is a powerful inward pull, and that's called oncotic pressure or colloidal osmotic pressure.
And this pull is generated by proteins.
Almost entirely. It's exerted by large plasma proteins, primarily albumin, which are too big to easily pass through the capillary wall, so they act like giant sponges, pulling fluid back into the vessel.
So if I'm a clinician, the critical takeaway here is the direct link between that pulling force and my patient's nutritional status. If a patient's albumin levels drop, say, below 2.5, what's the immediate clinical consequence I should be looking for?
Edema. It's almost inevitable.
Because there's no sponge.
There's no sponge. Low albumin means low oncotic pressure. The hydrostatic pressure keeps pushing fluid out, but there's not enough protein to pull it back in. That fluid just sits in the interstitial space, leading to peripheral edema, or much worse, pulmonary edema or ascites.
So monitoring a patient's albumin is a direct clue about their risk for edema and even potential third spacing.
Absolutely. It's a key predictive value.
Okay, so that's movement across capillaries. What about across the actual cell membranes?
Right, so let's start with the passive methods, the ones that don't require energy. First is diffusion.
High concentration to low concentration.
Simple as that. It's the movement of solutes. This includes gases like oxygen and carbon dioxide. Simple diffusion is direct, but there's also facilitated diffusion, like for glucose, which needs a specific protein carrier to help it across the membrane. But it's still passive. It's still following that gradient.
Okay, and then the most important one for volume, osmosis.
Yes. And this is the movement of water only. And the rule here is inviolable.
Water follows solute.
Water follows solute. Water will always move from an area of low solute concentration, where there's more water, to an area of high solute concentration, where there's less water, across a semi-permeable membrane. This single process is what regulates the volume split between inside and outside the cells.
And finally, the system's power engine.
Active transport. This is movement against the concentration gradient, from low concentration to high. And because it's going uphill, so to speak, it requires a direct input of energy, of ATP.
And the classic example is the sodium-potassium pump.
It's the quintessential example. It uses ATP to constantly pump sodium out of the cell and potassium into the cell. This is what maintains those vastly different concentrations of ions inside versus outside the cell, which is fundamental for nerve conduction, muscle contraction.
The heartbeat itself.
The heartbeat itself. If you inhibit this pump, the cell swells, sodium accumulates inside, and potassium leaks out. It's a cellular disaster.
Understanding that fluid movement leads us directly to the clinical assessment concept of fluid spacing. We have to be able to differentiate where the fluid is distributed because that dictates the entire treatment plan.
It really does. So first spacing is the goal. That's a normal, balanced distribution between the ICF and the ECF. No intervention needed. You just monitor and maintain.
Then there's second spacing.
This is the common one you see every day. It's an abnormal accumulation of interstitial fluid, in other words, edema. But the crucial insight for the clinician is that this fluid is still accessible.
We can get it back.
We can often mobilize it using diuretics or by elevating a limb to reduce that hydrostatic pressure. Examples are peripheral edema from venous insufficiency, or the fluid backing up into the lungs' pulmonary edema during a heart failure exacerbation.
And the really challenging one is third spacing.
This one is tough. This is fluid accumulation in a non-functional trapped space, and it is not easily exchanged with the ECFs. It's sequestered. Think of ascites, the fluid in the abdomen.
Or the massive edema you see with severe burns or sepsis.
Exactly. And the patient looks incredibly swollen, but their functional circulating volume, the plasma in their vessels, may be dangerously low.
And that's a huge clinical dilemma, isn't it? The patient looks overloaded, but their blood pressure is crashing because the fluid isn't where it needs to be. So how does the nurse track the true volume status in real time?
The single most critical non-invasive assessment tool is the daily weight.
A non-negotiable metric.
Absolutely. Because 1 liter of water weighs 1 kilogram, A rapid change in weight gives you immediate objective data on volume status that is often more accurate than just looking at vital signs.
So if a patient gains 2.5 kilos overnight.
They've retained 2.5 liters of fluid. End of story.
Hmm.
And conversely, if they lose 2 kilos after you give them a dose of a diuretic, you know that diuretic successfully pulled off 2 liters. It's just pure objective data.
Okay. We've established the map, the geography of the water, but water alone doesn't conduct the body's electricity. For that, you need the dissolved elements, the conductors we call electrolytes.
Right. And electrolytes are just minerals that, when they're in a solution, they dissociate into electrically charged ionizations, which are positive, and anions, which are negative. They're the engines of communication in the body.
Essential for nerve impulses, muscle contraction.
Everything. So we can focus on location, because that's what's clinically relevant. The extracellular fluid, the ECF, is overwhelmingly regulated by sodium, which is the primary ECF cation, and chloride, the primary ECF anion.
Which is why changes in sodium are so often synonymous with changes in volume status.
Exactly. Conversely, the intracellular fluid, the ICF, is dominated by potassium, the primary ICF cation, and phosphate. We also find a lot of magnesium concentrated inside the cells. This compartmental difference is the core principle of cellular life.
Let's just briefly hit their functional roles, but let's keep the focus on the clinical stakes.
Good idea. So sodium is the volume manager. Water follows sodium. It maintains blood pressure and nerve impulses. Potassium is the rhythm keeper. It controls cardiac rhythm and muscle contraction. And even minor changes outside its tight normal range are immediately cardiotoxic.
Calcium controls neuromuscular excitability, blood clotting, bone strength. Its imbalances show up as either severe muscle hyperactivity or profound weakness.
And magnesium is the stabilizer. It's vital for enzyme function, and it acts as a kind of natural calcium channel blocker, influencing both cardiac and neuromuscular function. We often see severe electrolyte issues linked to low magnesium, so it's critical to check that value alongside potassium and calcium.
So if these electrolytes are the conductors, what's the orchestra leader? What's the system that ensures everything stays in balance?
That control center is the hypothalamus. It acts as the body's main fluid sensor, constantly monitoring plasma osmolality, the solute concentration and blood volume. And when those values deviate, it orchestrates the entire response.
And the simplest response is thirst.
Right. The thirst mechanism. If osmolality increases, we're getting dehydrated or blood volume drops, the hypothalamus just signals the person to drink water. It's the body's fastest, most direct solution.
But then there's a more complex hormonal response.
Yes, the regulation of antidiuretic hormone, or ADH, which is released by the posterior pituitary. High osmolality, or low volume, signals the release of ADH.
And clinically, what does ADH do? It dictates whether you retain water or excrete it?
That's it. ADH makes the kidney collecting ducts permeable to water, causing water to be reabsorbed back into the blood. This concentrates the urine and restores blood volume.
So the critical clinical insight here is when that system dysfunctions.
Precisely. If you have too little ADH, which is what happens in diabetes insipidus or DI, the body just flushes massive amounts of dilute urine, leading rapidly to severe dehydration and hypernatremia because you can't reabsorb water.
And the opposite.
The opposite is SIADH, syndrome of inappropriate ADH. Here you have too much ADH. This causes pathological water retention, resulting in a delusional state where the patient looks okay, their volume status seems normal, but they have dangerously low, often life-threatening hyponatremia.
So the nurse has to be monitoring fluid status, specific gravity of the urine, and serum sodium constantly in those patients.
It's a top priority.
Okay, moving to the volume retention system, we have aldosterone.
Right, from the adrenal cortex, part of the crucial RAS system. This is activated by low blood pressure, low volume, or low sodium.
And aldosterone is the sodium water saver.
Its main action is to enhance sodium reabsorption in the kidneys. And since water follows sodium, this boosts blood volume and blood pressure. But it comes with a trade-off.
It gets rid of potassium.
It promotes potassium excretion. So understanding aldosterone is key. If a patient has an Addison's crisis, not enough aldosterone, they lose sodium and water, their blood pressure tanks, and their potassium goes up.
Hyperkalemia.
Right. And if they have hyperaldosteronism, they retain fluid and often develop hypokalemia, low potassium. You have to track sodium, potassium, and blood pressure together.
All of these hormonal systems really operate through the body's powerhouse regulator, the kidneys.
They're the primary architects of this whole balance. They filter plasma, but here's the key metric. They reabsorb approximately 99% of that filtrate. They only produce about 1.5 liters of urine per day in a healthy adult.
That remarkable reabsorption ability gives them incredible control over volume and electrolytes, which means clinically, if a patient has an acute kidney injury, or CKD.
Fluid overload and life-threatening electrolyte swings, especially hyperkalemia, are pretty much inevitable. So assessment via urine output, daily weights, and renal labs is just paramount.
And finally, the cardiac regulation system gives feedback on volume.
Right. When the heart senses increased stretch due to high volume like in heart failure, it releases natriuretic peptides, ANP from the atria, BNP from the ventricles.
And these are basically nature's own diuretics.
That's a great way to think of it. Their action is to promote sodium and water excretion natriuresis, and critically, they inhibit the retention hormones, renin, aldosterone, and ADH. They tell the body to relax and dump the excess fluid.
Which is why measuring BNP levels is the gold standard for diagnosing heart failure and confirming if a patient's shortness of breath is from cardiac fluid overload.
Exactly. It's a direct clinical application.
Okay, let's move into the major clinical applications, starting with sodium and chloride, the volume managers. We've established that sodium is the ECF ruler, and because the brain is in a fixed, bony vault, any rapid shift of water into or out of brain cells is an immediate neurological emergency.
Absolutely. Let's start with hypernatremia, which is a serum sodium above 145. This means the ECF is hypertonic.
And the central pathophysiology here is the shrinking cell?
Yes. The high concentration in sodium outside the cell literally pulls water out of the cells via osmosis. Brain cells lose water, they shrivel up, and this tension and compression on neural structures is what causes the classic neurological symptoms.
And the causes are key to figuring out treatment, right? Did the patient lose water or did they gain sodium?
That's the first question you have to ask.
Yeah.
Water loss is more common. Inadequate intake, especially in confused or elderly patients, fever, or that excessive dilute urine output we see in diabetes insipidus. Sodium gain is less common, but can happen from, say, iatrogenic administration of overly concentrated IV solutions.
And the clinical signs are overwhelmingly neurologic because of that brain cell dehydration.
Right. Intense thirst, if their thirst mechanism is working, followed by confusion, restlessness, irritability, lethargy, hyperreflexia, muscle twitching, and in severe cases, seizures and coma.
So the nursing assessment here has to be on high alert.
It's paramount. You have to assess neural status continuously, every hour if it's severe, checking their level of consciousness, looking for subtle signs of irritation or weakness, and of course, monitoring INO and daily weights religiously.
The intervention then is water replacement.
Yes, using hypotonic IV solutions like 0.45% ACL or D5W. The goal is to slowly lower the ECF concentration, which allows water to gently shift back into those shriveled cells.
And this leads to a huge critical caution for hypernatremia.
Yes, the critical caution is that you must correct the sodium concentration slowly. You're aiming for no more than a 10 to 12 point decrease in the first 24 hours.
Because if you correct too fast...
If you correct too fast, the ECF rapidly becomes hypotonic. Water then rushes into the previously dehydrated brain cells. This causes massive cerebral edema, swelling the brain against the skull, and that can lead to herniation, seizures, and death. Slow, careful titration is a life-saving nursing skill.
Now let's flip that balance to hyponatremia, so a serum sodium below 135. The ECF is now hypertonic.
And the inverse pathophysiology is at play, the swelling cell. The low concentration of solute outside the cell causes water to move into the cells by osmosis. This is what we call water intoxication, or when it's in the brain, cerebral edema.
And again, the causes are either sodium loss or water excess.
Right. Sodium loss comes from things like diuretics, especially thiazides, prolonged GI losses like vomiting or NG suction. Water retention is equally common in heart failure, cirrhosis, or that notorious SIADH, where the kidneys just aggressively retain water.
And the clinical signs are, again, primarily neurologic, this time due to the brain swelling.
Yes, subtle headaches, confusion, lethargy, personality changes, muscle cramps, and eventually seizures and coma.
So your assessment, again, is constant, meticulous neuroassessment, looking for signs of increasing intracranial pressure, monitoring for seizure activity, and of course, tracking INO and daily weights.
And the management requires differentiating the cause. If it's dilutional-like in heart failure or SIADH, the intervention is simple, but very hard for the patient. Fluid restriction. We have to stop adding fuel to the fire.
And if it's from sodium loss,
Then we replace volume, usually with IV isotonic saline, so 0.9% ACL. For very severe symptomatic cases, we might use hypertonic saline, but that's an ICU-level intervention with constant monitoring.
and here's the other critical caution for hyponatremia.
Yes, Rapid correction here is just as dangerous. If we raise the sodium too fast, we rapidly shrink the cells back, and that can cause osmotic demyelination syndrome, or ODS.
That sounds devastating.
It is. It's an irreversible neurological injury from the sudden change in tonicity. It damages the myelin sheath in the brainstem. So again, the goal is always slow, measured correction.
Okay, let's touch on chloride. It's often the silent partner to sodium.
It is. It's the primary ECF anion, works with sodium to maintain fluid balance, and it's vital for gastric acid. So chloride imbalances usually just mirror sodium or acid-based disorders.
So in hyperchloremia, what are we seeing?
High chloride, over 106. Causes are often dehydration or metabolic acidosis. The manifestations are generalized weakness, deep and rapid breathing, Kussmaul breathing, as the body tries to blow off CO2 to compensate for the acidosis, and altered LOC.
And the intervention is basically treating the underlying cause, right? Give hypotonic IV solution, take fall precautions.
Exactly. And conversely, hypochloremia, low chloride, is often seen after massive GI losses, prolonged vomiting, aggressive NG suctioning, because you're losing all that hydrochloric acid.
Symptoms there would be more like neuromuscular excitability, twitching, tremors, and maybe slow, shallow breathing as the body compensates for a metabolic alkalosis.
Right. And treatment is often IV normal saline to replace both the sodium and the chloride, and careful INO monitoring.
Okay, let's transition now to the electrolytes, where imbalances can stop the heart in minutes. Potassium and calcium, these require immediate life-saving interventions.
Yes, and let's start with hyperkalemia, potassium over 5.0. This is, without exaggeration, a life-threatening emergency that demands immediate intervention. Excess potassium in the blood rapidly impairs the heart's ability to conduct electrical impulses.
So let's break down the causes into those three critical pillars. First and most common is decreased renal excretion.
Right. Kidney injury or failure is the #1 cause. But you also see it with Addison's disease because of low aldosterone and with the inappropriate use of potassium-sparing diuretics.
The second pillar.
Increased intake. This is usually iatrogenic, giving an IV potassium infusion too fast, or maybe a massive transfusion of old blood products where the cells have broken down and released their potassium.
And third, the dangerous shift from inside the cell to outside.
Yes, the shift from ICF to ECF. This happens in severe acidosis, where hydrogen ions shift into the cells and force potassium out, or with massive tissue breakdown like in rhabdomyolysis, severe trauma, or extensive burns.
The clinical manifestation that makes this a true emergency is the profound cardiac toxicity.
Absolutely. You have to monitor the ECG constantly for specific changes. The hallmark sign is peaked T waves. They look tall, narrow like a tent. That's followed by a widened QRS complex and ultimately a sine wave pattern that leads to VFib and cardiac arrest.
You'll see other symptoms like muscle weakness and cramping, but the ECG is the true indicator of the immediate life threat.
It is. So the nursing management protocol for severe symptomatic hyperkalemia is an urgent multi-step process. We call it the hyperkalemia cocktail. And the immediate priority is not lowering the potassium.
It's protecting the heart.
Exactly. So step 1, cardioprotection. You administer wavy calcium gluconate. This stabilizes the cardiac cell membrane, makes it resistant to the dysrhythmic effects of the high potassium. It works in minutes, and it's the first line of defense to prevent VFib.
But it doesn't actually lower the potassium level.
Not at all. It just buys you time. So step 2 is shifting potassium intracellularly. We use IV insulin, usually 10 units, along with 50 grams of glucose to prevent hypoglycemia. Insulin is a powerful driver that pushes potassium from the ECF back into the cells, temporarily lowering the serum level.
And step 3 is actually getting it out of the body.
Right. Step 3, actual removal. We use agents that promote excretion. Kayexlay is often given. It exchanges sodium for potassium in the GI tract. But if the patient has renal failure or extremely high refractory potassium, emergency dialysis is the definitive treatment.
Patient teaching then would have to include a review of all their meds and strict limitation of potassium-rich foods.
Right.
Okay, now, hypokalemia, potassium less than 3.5, often less acutely threatening, but still carries a significant risk.
It does. Low potassium makes the cells less excitable, leading to a generalized lethargy and sluggishness.
Causes are usually increased loss, right? GI losses like vomiting and diarrhea, or renal losses from loop diuretics like furosemide.
Right. Or it can be a shift into the ICF, which you see when you treat DKA with insulin, or just simple inadequate intake.
The clinical manifestations are different ECG changes here.
Yes, you'll see flattened T waves, ST depression, and the appearance of a distinctive U wave, which is a small wave that follows the T wave. These changes also increase the risk of ventricular arrhythmias.
But the other big signs are that generalized muscle weakness and decreased GI motility, which can lead to a paralytic ileus.
Yes. And the critical safety concern here for nursing assessment is the relationship with digoxin. Hypokalemia sensitizes the heart muscle to the effects of digoxin, dramatically increasing the risk of digoxin toxicity, even if their dig level is technically normal.
So you have to monitor digoxin levels, muscle strength, including respiratory effort, and bowel sounds.
All of it?
And the intervention is potassium replacement, but this comes with an absolute non-negotiable safety rule.
Potassium must never be administered via push or bolus.
Never.
Doing so will cause immediate lethal cardiac arrest. It has to be diluted and administered slowly, usually no faster than 10 millimoles per hour through a peripheral line and always on a pump.
Okay, let's move to calcium, our third rhythm keeper. And we have to remember its inverse relationship with phosphate.
Right. As calcium rises, phosphate often falls, and vice versa. So with hypercalcemia, which is high calcium, you see a dampening of neuromuscular excitability.
Causes here are things like hyperparathyroidism or malignancy.
Yes, the effects are often described as moans, groans, and psychic overtones, lethargy, depression, fatigue, confusion, muscle weakness. On the ECG, you see distinct shortened QT interval.
So nursing assessment is all about safety risk for falls, risk for bone fractures.
Exactly. Encourage mobilization, push fluids, and you might use loop diuretics to help excrete the calcium.
Conversely, hypocalcemia, low calcium, rapidly increases neuromuscular excitability.
The causes are often hypoparathyroidism, maybe after neck surgery, chronic kidney disease, or low magnesium.
And the effects here are dramatic.
They are. You see increased excitability, tingling, muscle cramps, tetany. And the two classic severe signs you have to assess for are Schwastek's sign.
The facial twitching when you tap the nerve.
Right. And Trousseau sign, which is the carpal spasm you get when you inflate a blood pressure cuff.
And on the ECG, this one is critical. Hypocalcemia causes a dangerously prolonged QT interval, which significantly increases the risk for lethal arrhythmias like torsades de pointe.
It does. So management is aggressive IV calcium gluconate for the tetany, oral calcium and vitamin D, and critically seizure precautions because of that high neuromuscular irritability.
And briefly, phosphate, which is vital for ATP energy. Its imbalances often mimic the calcium disorders.
Right. Hyperphosphatemia is most commonly caused by renal failure. And because of that inverse relationship, the primary clinical sign is actually the symptoms of hypocalcemia, tetany, and paresthesia.
And hypophosphatemia is a serious concern, often seen during aggressive nutrition repletion, like starting TPN or an alcohol withdrawal.
And since phosphate is required for ATP, low levels cripple cellular energy. You see severe CNS dysfunction, confusion, coma, and life-threatening respiratory muscle weakness. This can be masked by the patient's primary diagnosis, so you have to be proactively monitoring labs in those at-risk patients.
We've established the dynamics and the consequences. Now let's translate these shifts into measurable, actionable data with the diagnostic toolkit. This is where the lab work turns into high-level clinical interpretation.
And because the kidney is the primary regulator, assessing its function is always step one. We rely on three key values that the nurse has to interpret together.
Okay, first is BUN, blood urea nitrogen.
Right. Waste from protein breakdown. It reflects kidney function, but it's also sensitive to things like dehydration and GI bleeding, so it's not always the most specific marker on its own.
Which brings us to the more reliable marker, creatinine.
Exactly. A waste product from muscle metabolism produced at a constant rate. Because it's excreted almost entirely by the kidneys, creatinine is a much more specific and reliable marker of true kidney function than BUN is.
And the third value, which is often calculated for us, is the GFR, or glomerular filtration rate.
Which is the best overall indicator of kidney function. A falling GFR is the definitive measure of kidney decline.
But the high-level application here is looking at the BUN to creatinine ratio.
Yes, this is a core interpretive tool. If both are elevated, you know there's kidney dysfunction. But if the BUN is disproportionately elevated compared to the creatinine ratio greater than 20:1, this strongly suggests pre-renal failure.
Meaning the problem is poor perfusion to the kidney, like from dehydration or shock?
Exactly. And that's often reversible with fluids. But if the ratio is closer to normal, like 10:1, it suggests intrarenal failure damage inside the kidney itself. And that distinction is vital for management.
Moving on, the urinalysis, or UA, is a simple test that gives us a ton of information.
It's incredible. You have to get a proper sample, of course, and then correlate the findings. But the presence of abnormal substances gives you immediate diagnostic clues.
For instance, elevated protein in the urine almost always indicates some kind of kidney dysfunction or glomerular damage.
And if you find glucose in the urine, it points to uncontrolled diabetes mellitus. If you find ketones, it indicates the body is breaking down fats for energy, like in DKA or starvation.
And microscopically, if you see abnormal amounts of red or white blood cells, it signals inflammation, infection, or injury somewhere in the urinary tract.
But critically, the presence of abnormal casts, specifically red blood cell or white blood cell casts, is a strong indicator of serious inflammation happening inside the kidney tubules themselves. Things like glomerulonephritis. It localizes the problem for you.
Beyond the kidney, metabolic panels give us critical insight, starting with that volume regulator protein, albumin.
Right. We already talked about it, but a normal albumin is 3.5 to 5.0. It's the master of oncotic pressure. Clinically, a low albumin is a huge red flag for poor nutritional status, liver dysfunction, or inflammatory states that lead to capillary leak and edema.
We also linked back to cardiac regulation with BMP. High BMP confirms heart failure. It's the essential tool for diagnosing fluid overload that's coming from the heart.
And if we're looking at systemic health, the pancreatic enzymes are vital. Lipase and amylase are checked for abdominal pain. But lipase is much more specific for pancreatic inflammation, and it stays elevated longer, providing a more reliable diagnosis of pancreatitis.
We also have to integrate glucose control into this picture. Hyperglycemia leads to osmotic diuresis, which is a major cause of pure water loss and hypernatremia.
Absolutely. So checking fasting glucose and an HbA1c is essential for managing overall F&E risk in diabetic patients.
And since we're on metabolic status, let's introduce a really high-level interpretive tool, the anion gap.
Yes. This is a calculated value based on the serum electrolytes. The normal range is about 8 to 16.
And why is this calculation so crucial?
It helps you determine the cause of metabolic acidosis. If the anion gap is high, it means there are excess unmeasured acids built up in the blood. Clinically, this points to things like DKA, renal failure, lactic acidosis from shock, or toxic ingestion.
So it immediately narrows down your differential diagnosis.
Immediately. If the anion gap is normal, the acidosis is usually caused by bicarbonate loss, like from severe diarrhea. Recognizing a high anion gap acidosis is an invaluable shortcut for clinical decision-making.
So what we've seen today is that the body's fluid and electrolyte balance is this constant dynamic interplay of physical pressures and chemical gradients, all orchestrated by the kidneys and the heart. This internal ocean is just incredibly sensitive, and the stakes are life itself.
Right, and mastering these concepts really is the shortcut to seeing the entire clinical picture. It moves you from just reading lab values in isolation to understanding the narrative those numbers are telling you.
Knowing that a patient's peaked T-wave is screaming for immediate calcium gluconate, or recognizing that a headache in a patient with low sodium means the brain is swelling. That is the essence of high-stakes, informed care.
Right, interpreting the entire patient's status just by looking at those core numbers, sodium, potassium, calcium, BUN, creatinine, and using those interpretive tools like the BUN to creatinine ratio and the anion gap, that allows you to anticipate and intervene preemptively.
Which is always the best outcome for the patient.
Always. You know, we spent a lot of time today discussing fluid loss and excretion, but consider this provocative thought. We know the GI tract normally secretes approximately 8,000 milliliters. That's 8 liters of digestive fluids daily into the stomach and intestines. And nearly all of that massive volume is reabsorbed before excretion. Now, when vomiting or persistent diarrhea occurs, preventing that absorption, the body essentially loses a volume equivalent to a quarter of its total body water daily.
That's a staggering volume.
It is. So think about the sheer volume shock and electrolyte chaos that rapid, massive failure of daily reabsorption demands, and how quickly that situation escalates, requiring an immediate aggressive nursing response to prevent catastrophic circulatory collapse.
A truly critical concept to hold on to when you're assessing your next patient's volume status. Thank you for joining us for the deep dive.
We'll see you next time.